There are three different forms of skin cancers that you will have to be familiar with, and these include melanoma, squamous cell carcinoma, as well as the basal cell carcinoma. So starting with melanoma, this is the most fatal form of skin cancer that has the high potential for metastasis. And in fact, tumors of more than 2 millimeter thickness have high potential to metastasize. And so therefore, one measure of survival in these patients is the depth of the tumor invasion. So if on the exam they give you different characteristics of the tumor and then they say which of the following is the most important prognostic factor, they say the size of the tumor, the shape of the tumor, the color of the tumor, and then among the answer choices you see the depth of the invasion, then that's the most important factor because that determines the higher risk of invasion to the lymph nodes and then from there on metastasis to the distant sites. And then the tumor markers that can be used for monitoring the progression or regression of metastasis associated with the melanoma is the S100. Now, as for the clinical features of the melanoma, these form of lesions present with the ABCDE characteristics, where A stands for asymmetry. So here you can see that the right side of the image is not symmetrical with the left side. So there is asymmetry in the lesions. There is also border irregularity. So you can see how the border here is so irregular. And then C stands for color variegation. So here you can see that at the center here we have the light color for the tumor, while on the other sides, on the corners, we have a darker color. So there is color variegation, and then diameter of greater than 6 millimeter. So the diameter of greater than 6 millimeter is another characteristic of the melanoma. And then finally, there is evolution in size and color and shape. So a patient may present to you and say, you know, I had this lesion on my back, but I've noticed that it's getting bigger and it's also changing in size and color. And that's another characteristic feature of melanoma. Now, in terms of the risk factors, genetics is an important risk factor to melanoma. And in fact, mutations in the gene BRAF as well as P16 has been associated with the development of melanoma. So the memory aid that I have for you here is that Brad Pitt donated $100 to the Melanoma Foundation at age 16. So Brad stands for the BRAF gene, and then P at age 16 stands for P16. And then can you tell me what $100 stands for? So if you recall, I told you that the tumor marker that is used for melanoma is the S100. So if you memorize the sentence, Brad Pitt donated $100 to the Melanoma Foundation at age 16, then you will know that it's the BRAF gene and the P16 gene mutations that are associated with melanoma, and you will have to follow up on the progression of the tumor via the S100 tumor marker. The other risk factors include the high nevus count. And so generally, patients that have nevi of more than 25 are at increased risk of developing melanoma. Other risk factors include atypical or dysplastic nevi. And then finally, UV exposure is another risk factor to melanoma. And then there are different forms of melanoma. The first class is the superficial spreading, where there is asymmetry and color variegation. The second type is nodular melanoma, where these lesions present as discrete nodules with no identifiable radial growth. But then there is vertical growth that is associated with this type of melanoma. Lentigo maligna is another form, and this form of melanoma has the best prognosis. And so these are usually found in the sun-damaged skin, and the pattern of growth is starting with the superficial growth and then later on progressing into nodular growth where there would be vertical invasion of the skin. And then the last type is the acral lentigo, which is found on the palms, soles, as well as nails. Now, in terms of the treatment for melanoma, you should consider surgical excision with wide margins. That should be 2 centimeters. So here, let's go back to the melanoma that we had here. So in addition to cutting out the melanoma, you should also have a 2 centimeter margin. So that's the shape that you should be cutting out the tumor in these patients. And then you should also use the sentinel lymph node biopsy to check see if there is an invasion of the lymph nodes. So the fact that the melanoma is highly fatal with a high risk of the metastasis, it's important to biopsy the lymph nodes to make sure that the invasion has not yet started. And so the way you do it is that you use a blue dye or a radioactive dye. You inject that at the site of the lesion before you actually excise the melanoma. And then you follow the dye and see which of the lymph nodes are being stained first. And so this way you will find out which are the first lymph nodes that absorb the dye. And so if there has been a metastasis, these lymph nodes would have been affected first. And so this technique provides you with the advantage of just removing a few lymph nodes and checking them on biopsy to see if there is melanoma invasion. And so with this technique, you didn't have to remove the entire lymph nodes. And then you can consider adjuvant therapy with the interferon alpha to prevent recurrence. And then finally, for patients that have BRAF mutations, which are V600E mutations, you can consider supplying these patients with vemurafenib, which is a BRAF kinase inhibitor. The next form of skin cancer is squamous cell carcinoma, which is the second most common skin cancer after the basal cell carcinoma. And this type of skin cancer is strongly associated with UV light exposure, where it would cause DNA damage, as a consequence of which it will cause proliferation of keratinocytes. And so now from here on, there would be malignant transformation. And so these lesions generally present with hyperkeratosis as well as ulcerative lesions with scales. And I'm going to show you an example in a minute. Now, the risk factor to squamous cell carcinoma, in addition to the UV light, other risk factors include light colored skin, like in patients who have albinism, immunosuppression, like for instance in organ transplants or in patients with HIV, age, smoking, human papillomavirus itself can cause squamous cell carcinoma, like for instance penile or anal squamous cell carcinoma, and then arsenic, as well as BRAF inhibitors like vemurafenib. So this medication, you recall, that has been used for the treatment of melanoma. This, however, increases the risk of squamous cell carcinoma. Now, in order to develop squamous cell carcinoma, UV light produces the actinic keratosis, which is a precursor lesion to a squamous cell carcinoma. And these lesions generally present with proliferation of atypical epidermal keratinocytes that present with erythematous as well as scaly lesions. So here you can see that there are these red lesions with some scales that are all around erythematous lesions. And so in order to prevent further progression of actinic keratosis, it's important to provide these patients with sunscreen, which has a sun protection factor of more than 30, and then you should also consider using protective clothing. And then other treatment options include destructive therapies, like for instance surgery or cryotherapy. And then finally, you can consider topical medications, like for instance 5-fluorouracil as well as imiquimod. And so actinic keratosis can now progress into the squamous cell carcinoma. So as I just discussed, actinic keratosis is a precursor to the squamous cell carcinoma. And if it's left alone and further sun exposure is there, squamous cell carcinoma can develop, which presents with hyperkeratosis as well as ulcerative lesions and scales. And so unlike melanoma, squamous cell carcinoma as well as basal cell carcinoma, which I will discuss next, will rarely metastasize. Characteristic of this form of cancer is that on histology you will see keratin pearls, and then you also see the intercellular bridges, also known as desmosomes. So if you look up on cells that are close to each other, you will see that there is this intercellular bridge, also known as desmosomes, between the two cells. Now, one other question that you may be asked is that which one of your lifts? Is it the upper or the lower lifts that is at increased risk of developing squamous cell carcinoma? And so the memory aid that I have for you is called BS. So the upper lip has an increased risk of developing basal cell carcinoma, while the lower lip has increased risk of developing squamous cell carcinoma. Now, as for the treatment options for squamous cell carcinoma, similar to actinic keratosis, you could consider destructive therapies like, for instance, surgery, cryotherapy, as well as electrical surgery and radiation therapy. And then finally, topical medications would be the same as what I just discussed. You can provide them with 5-fluorouracil as well as imiquimod for squamous cell carcinoma. Now, Keratoacanthoma is a variant form of squamous cell carcinoma that also has a rare potential for metastasis, and this type of squamous cell carcinoma rapidly develops and then rapidly resolves itself. So if on exam you hear about a form of skin cancer that rapidly develop and then rapidly resolve, you should start thinking of keratoacanthoma. The final form of the skin cancer is the basal cell carcinoma, which is the most common form of the skin cancer. So therefore, this is the most common form of skin cancer. And this type of skin cancer arises from the basal layer of the epidermis. So melanoma arises from melanocytes. I just discussed that squamous cell carcinoma arises from the keratinocytes. So here the DNA damage will cause abnormal keratinocytes. And so the basal cell carcinoma is the third one, which arises from the basal layer of the epidermis. And then similar to squamous cell carcinoma, this type of skin cancer is rarely metastasizing. So now you can see that squamous cell carcinoma and basal cell carcinoma rarely metastasize, while melanoma had high risk of metastasis. And so that's the reason that melanoma is the most fatal form of the skin cancer. Now, one other feature of basal cell carcinoma is that despite it rarely metastasizes, however, it's very locally invasive and can destruct the skin as well as surrounding tissues, like for instance the bone. Now, as for the clinical presentation of basal cell carcinoma, they present with purely lesions that commonly associated with telangiectasias. So here you can see on the surface, we have all these small telangiectasias that are running. And then on histology, you will see the palisading nuclei. So here we have the palisading nuclei, where the edge of the nuclei is darker compared to the center. So here you can see that the edges that are shown by the arrow is actually darker than the center. And so this is referred to as palisading nuclei. And then finally, going back to which of these lips are at increased risk of basal or squamous cell carcinoma. So lip cancer is BS, so the top one is at increased risk of developing basal cell carcinoma, while the lower one is at increased risk of developing squamous cell carcinoma. Now, as for the risk factors to basal cell carcinoma, these risk factors include UV as well as ionizing radiation, and then immunosuppression, like for instance HIV and organ transplant, are other risk factors to basal cell carcinoma. As for the treatment options, you could again consider surgical excision, as well as electrodesiccation and curettage. And then finally, for topical treatment, again, you can use the same medications that are used for actinic keratosis and squamous cell carcinoma. And can you tell me what those are? So the topical medications are 5-fluorouracil as well as imiquimod. And that concludes our discussion of different forms of skin cancer.